All right, this is cardiovascular system. We're going to talk about some diagnostic studies. You don't get confused. Somehow the last couple of slides I recorded got lost, so I'm having to re-record them. So I'm just going to start from the diagnostic test when we start to talk about the cardiac biomarkers. So if this is repetitious, I'm sorry. The one thing that I want to talk about is the creatine kinase that is found in a variety of organs and tissues. There's actually 3 enzymes that correlate with the creatine kinase. You also see it written as CK. The isoenzymes are important because it tells you what's affected, because the creatine kinase is a breakdown telling you there's something in the muscle. So if you have a CKMM, that's skeletal. If you have a CKBB, we're looking at the nervous system. But the one that we're focused on right now is your CKMB, which is indicative of heart muscle damage. This usually begins to elevate or rise in 3 to 6 hours. That is considered the onset. The peak is 12 to 24 hours, and then it returns back to baseline within a 48-hour period. The other thing they may take or may draw blood and look at the value of a myoglobin. The myoglobin is a protein that's found in the cardiac and skeletal muscles. The other thing is a C-reactive protein, which is what's on your slide currently. The C-reactive protein is produced in the liver, and usually will be elevated in indications of inflammation. The next couple of things we're going to talk about are cardiac natriuretic peptides. There's 2 different kinds. There is an ANP, I'm going to switch colors, ANP, that is our atrial natriuretic peptide, and then there is a BNP, which is just a B-type natriuretic peptide. These usually will elevate because what happens is you have fluid in the lungs, fluid in the body, fluid builds up. We have in our body natural diuretics that are these 2 components, an ANP and a BNP. So that is sent out into the body to try to diurese our body on our own. So when we draw lab work, that is elevated in the blood, and what they are looking at when that is elevated is possible heart failure. So the picture that you're looking at on the PowerPoint is an echocardiogram. I just want to remind you, in case it was on one of the slides that got lost, all of your diagnostic studies are housed on page 699 to 703. It does a nice breakdown of the study, the description purpose, and the nursing responsibilities, because that is your responsibility. You guys are going to be tested on your knowledge about, if I have a patient going for an echocardiogram, what am I responsible for knowing ahead of time? Is there any preparation I have to do for this patient versus if I have someone going for a cardiac cath? So those studies are listed throughout those pages. The echocardiogram is an ultrasound, essentially, of the heart. It is an ultrasound of the heart, and it can give us information about abnormalities, valvular structure, cardiac chamber size and content. So if we're looking or want to diagnose an enlarged heart, they could do an echocardiogram. We're also looking at ventricular and septal motion, the pericardial sac itself, and the ascending aorta. The other thing we are obtaining is something called an ejection fraction. This is an important number. The ejection fraction, or you will see it written EF, is the percentage of the end of diastolic blood that is ejected during systole. So that is a measurement tool. So for example, if I have a patient and they do an echocardiogram and determine this patient has a 35% ejection fraction, they do not have great perfusion in their heart. It is not pumping effectively. And when we are looking at ejection fraction, we are talking about the function of the left ventricle. So the last couple of tests that I want to talk about and go over, because they're pretty common and you're going to see them, especially if you guys do clinicals on 3 East or West. You can have a patient who has something called a TEE. A TEE is a transesophageal echocardiograph. This is a more precise echo of the heart. It has a 2D echo kind of visual to it. It's nice because it's actually important, because what they do is they go in with a flexible scope. They actually go down into the esophagus. So the tip of the imaging of the heart is looking at the great vessels. So they go in the esophagus to the level of the heart, and then they're evaluating for mitral valve disease, endocarditis. They're also looking for thrombosis. Now I want you guys to think about, why would I want to do a TEE if I'm evaluating a thrombosis and not some other method? So keep that in mind. The other thing they can do is look for the source of an actual cardiac emboli. There are some risk of TEE. They're very low, but there are some complications that could occur. Tearing of the esophagus, hemorrhage, you could cause dysrhythmias. You can also cause the patient to vagal or vasovagal. The other thing is, if you have a patient with a history of esophageal disorders or dysphagia or actual radiation that they had to the chest wall, they probably should not have a TEE done. One of the other things is, as the nurse, it's your responsibility, because we are going in the esophagus. When that patient returns, you have to assess for a gag reflex before you could administer any oral intake or medications. The next test that we're going to talk about is the cardiac cath. Cardiac catheterization is a test where it gives us information about CAD. So we're doing cardiac cath. And we are also looking for coronary spasms, congenital and valvular heart disease, and ventricular function. Cardiac cath measures an intracardiac pressure and O2 levels. It also looks at your cardiac output, and it also looks at the ejection fraction. What happens is, injection can be given of dye, so you have to make sure your patient does not have an iodine allergy, so that you can see the coronary arteries. And on page 706, figure 32-12 was actually showing you where the dye has been injected, and you can see the arteries. So that's a good example of seeing it. They can go into the right or left side of the heart. They can also use the arm vein, where they use the basilic or the cephalic vein, or they can use the leg vein, where they're going into the femoral. The one that Winchester's actually been doing a lot of when I've had students on 3 East and West has been where they've been using the actual arm vein. The patient does not have to lay flat for 6 hours. They're up and moving around a lot quicker, which is nice for the patient. They can also do something called a coronary angiograph. This is the part where they consider, when they inject the dye, they look at the arteries. Patients typically will feel a flush sensation when that dye is injected. So think of it kind of like a hot flash. Complications and things that you need to monitor as the nurse is bleeding or hematoma at the actual puncture site, a delayed allergic reaction to the dye. If someone's never had dye before, patient can get an infection, thrombosis, dysrhythmias. The other thing you need to make sure that you monitor, which is important, is that you're monitoring pulses distal of the injection site. So this finishes up our podcast for cardiac assessment.